All right, dear doctors, thank you so much for joining the session. This is Dr. Sharia, your mentor for MC, and I've been taking classes since last 9.5 years under our guidance. There is 1,200, 1,900 plus doctors have cleared. I think very soon, I think if we count, I think we'll hit the 2,000 doctors and many working in Australia. What we documented, it's more than 1,350 doctors are working, which we know. Many we didn't trace actually at some point, maybe loss in contact, but I'm sure they're also doing well. And some are into their way to make a job in Australia. It's getting competitive, it is true. And how it will be in coming days. So far, so good. Uh, Last year was good. The previous year was even more better, actually. So the lot question comes, how about 2000, this particular year, 2026? This is already, we are in June almost. So, I mean, halfway. So the second round of the job application, the first round, I would say it was decent. The second round, I think it will go same. That question remains how it will be in 2027, right? So that's a bigger question, like, how will be the approach for the doctors in 2027? Yeah. So a lot of things, a lot of speculation actually we see. That is how it is, right? So, I mean, we have to be careful in terms of like the preparation and a lot of other things. And in terms of few things which Australia in AMC website, they have published few things they didn't publish, few things from our experience we can tell as well. Actually, with the blended things, I'm going to guide you um, as much as I can in the beginning, and then we'll get into today. We have a session also coming up on GIT, so we'll also get into that one actually onto that GIT session actually. Now, this one I think I have shown you guys. So already we have seen some changes in regarding this. So some changes has been noticed, and these particular changes are like quite evident since April, actually, right? Especially more clinical oriented, more patient safety protocol, and a lot of doctors, especially psychiatric and ethical things, what they are thinking the right answer, probably the original answer is different. So, and some ethical questions are quite new at the same time, which probably it's not present in any question bank and in even recalls we didn't collect it. So the new things keep coming. Original recall documenting, especially the ethical ones, are quite difficult. You can understand. You imagine, you see a full ethical question, and unless someone has a photographic memory, very difficult that the full ethical question someone can memorize. So the uh, I was talking to a few doctors, who appeared in April and maybe didn't get through. Um, Few probably in our academia and general, I take an opinion or a poll. Everyone agreed with one thing that, there are more new questions, more raw questions. And thirdly, another thing, those people are much dependent, lastly, on the exam week recall things actually. They did quite bad in the exam. So here is the thing that you need to have a total preparation. A lot of doctors compared to, let's say, 5 years back, 6 years back, I was also teaching. There are a lot of students, so their study hours were much more. Nowadays, more contents, more question banks, more like companies out there. So people think, okay, we have so many shortcuts and this and that. And also understand one thing, the baseline and the level is no longer the same. So ANC baseline increased and the candidates, their total study and performance is also decreasing. That is one of the reason, that passing rates a bit dropping actually. But one thing is clear that AMC already has raised the bar actually. Now, previously you were expecting getting the same mark and passing. It is not happening. So you have to work more hard. So summary thing is like, officially the marking system does not show that, you have to get more, but honestly speaking, you have to do much better now actually in the exam. Is it clear so far? I mean, what they're trying to say and say what I'm trying to say regarding on behalf that, the parameter has increased, so you have to do much better, from now on actually. So that is one thing that is fully clear actually about the summarizing thing. The bar has increased, so you have to do like a double performance. That's the thing. If you are studying like let's say 6 hours, you have to study now 7, 8 hours. Okay, that is the only thing you can do. All right. Guys, just to hear me out, like, are you guys following the class? So just let me know in the comment section so that we can proceed to the next slide. All right. Now, here is the thing, more clinical oriented, more clinical reasoning questions are much more rather than the more like diagnostic question. They give a summary, what is the diagnosis? Those questions becoming less. Rather, the clinical reasoning, clinical oriented questions are much more. Actually, they put you in a scenario that questions are much more. This brings us to the point they give you a scenario and asking you, okay, what to do next? What is the next best approach? I'm talking about some medicine surgery. What is the most important emergency thing you can do? What is the most safest approach? That is, this brings us to the second point, patient safety protocol. So this brings us management things. This also brings us to the ethical question and the patient safety. Like, let's say patient safety first, or patient's wish first, or the patient party's opinion first. This kind of ethical things are more important as a doctor to safeguard yourself from a psychiatric agitated patient. That is also important. All right, so these all things are more important nowadays. Actually, it was there, but the number of questions are a little bit more, we found out. Also, so as the population health, like epidemiology and this kind of questions. Another thing, indigenous health, they're giving more emphasis, I think. In April, I would say, I have seen 2 months, right? I mean, since February, March, and then there is the April and the May. April was quite a different. May I figured out a little bit more easier than the April. It's my opinion after reviewing all the questions, actually, because there's a lot of backlashes, actually. Understand they are also a company, so they want more candidate to appear. So after that April exam, I think a lot of people cancelled in May. So that, I think, strikes them in any way, that why so many people are you know canceling the exam and this and that, get afraid. Like, already they knew from the April candidates, okay, they were not happy with the question and the pattern and so much new thing. But it is also true, they have announced. So now so many people are afraid, they scheduled more into, let's say, September or October, November. Like, they also want to, I mean, the candidates and the doctors also want to review the questions first, actually. You must be knowing one thing, that MC exam is an exam where you can change the exam freely for 1 year. Let's say if you take an exam date in September this year, till next year, September, I mean before September, that is the August, you can keep changing the exam free of cost, actually. Exam fees is high in any way, so probably they can give you at least this minimal changing option. But honestly, changing too many times is not usually healthier. Time, keep wasting. But it is also true at the same time, you should be taking the exam when you are sure for the exam. We keep telling this thing, actually. All right, so this is one of the things. So another thing is the indigenous health, patient safety. I mean, this slide we have shown you in past, actually. So so reasoning over memorization. So there's another group, they try to memorize things, actually. There's another group, they just try to go through the question bank. It's not enough. I'm telling again and again, thus depending on one particular question bank, a lot of people are talking about a question bank. It was not enough, actually. A lot of people have seen that one, actually. Okay, I mean, like 6,000, 7,000 questions, and so that is, you have to think, your total knowledge is important. Another student I was talking, that that I would say, the came from another course, and she failed, actually. And I was talking that, so I found, okay, she probably chose a, I mean, other than us there are also courses available. So she chose, okay, it's fine, anyone, it depends on you, end of the day, how you study and this and that. Few things also depends on tutor, definitely. But when I asking, like, okay, she said she took a theory thing, then she took a recall thing, but she was not our student. That she wanted to talk to me, that somehow she managed to find me. Okay, anyways. Then talking to her, like, I was trying to figuring out why her mark was so poor. I mean, it's like 201 was the mark. Like, normally, let's say, even some of our candidates, even they, if they cannot pass, the marks are at least nearly 230, 240, like this kind of marking, actually. So I asked, like, what went really wrong, actually. You took a theory course, you took a recall course. Anyways, it can be third parties. That's okay. At least, I mean, she has a brain, definitely, definitely. She also studied at the same time. So what went wrong? What went wrong? Okay. Now, of course, like courses matters. That is true. But at the same time, maybe something went very wrong. So I asked her later one thing that, so she said that, a lot of doctors whom they were studying, her study group appeared in last November due to some issues she couldn't appear in November. All right. Now, after the November, she couldn't study much, so study thing was little dropped, and she was not into that group. So solving the controversial one was affecting. Very important thing, solving the controversial. This brings us to the very important thing, solving the controversial recall altogether by a study group rather than going alone. So while talking, I figured out that she was studying alone later on, actually, after her study mates were studying or they finished in November, actually. All right. Now she was alone and then appeared in April that she couldn't get through, and mark was poor. In spite her friends passed, maybe one to fail, that's okay, but her mark was quite poor actually compared to any other actually. Then I asked another thing that uh, the last thing I was also trying to figuring out that uh, other than this thing, okay, material can matter, but she said, okay, she finished the theories with the course. Even though with the others, that's okay. Then she did some last moment recall things, but which she didn't get in the last moment, even though, as I mentioned, that these things will not work much actually, even though in our courses, this exam support group are given like free of course, but we think, these things may not work that much in coming days. Actually, your total preparation will work much. The last thing when I was talking that, did you appear in 3.5 hour exams? This is no, never before that. And I said, okay. Now, do you think this can be a important change? Actually, realistically, I was struggling with the time. But so this is things us to the point, guys. Very, very important that your this part actually your time management actually. So strategies, reasoning, your time management because the patterns are new than the before. So a lot of time goes in between actually, and some people just quickly finish just to satisfy themselves that okay, at least I finished the exam. Understand one thing, even out of 150 question, if you finish 120, you will be still judged. Your exam will be judged actually. But if it's below 120 out of 150 question, you are like disqualified from the exam. Okay, so some people like do it faster, but I mean does not most make sense actually. Okay, so and you can one thing, if anyone is hearing this thing first time, MC questions you cannot review like plan. Okay, previously MC questions you could review. It's a computerized based exam. So previously question we could review and there was an option, but now it's gone actually. So once you mark something and go to the next one, it's done totally. Okay, is this point is clear so far, guys? Is this point is so far clear that once you mark a question and go to the next one, you cannot come back. You are done with that one. So some people, in the middle part, so many ethical question, population health question, bastard question, so they become panic. They go more faster. All right. So that's one of the thing. In past, there used to be like in the last half of the exam, more juicy question used to come. That is not happening nowadays as well, actually. So, guys, it's very important in our academy. There are time mode practice questions are available as well, which I will take. Any courses and this and that. Recall courses has multiple. This time mode practice. Almost four, I think, we took in the last batch. I mean, it's a big one actually with 3.5 hour. And in the 5 months courses, we also took two big and small size a lot actually. The small size, let's not consider in that way. All right. So this is few of the things. So anyone whoever watching today as a trial, maybe some may not from our academy, but I want as a person, all of you to pass because of small mark you could got stuck. Another thing, because of your some faulty technique, you keep trying again and again, you fail. As a doctor, as a mentor of many doctors, like, I don't want anyone to get failed. Whoever get that mark will pass. So hear me out one thing, your time management has to be, so no matter you are with our course and any other course, make sure, you appear with time mode practice, which is the 3.5 hour. Okay, I'm asking again one more time. Is that clear so far, everyone? Other than the clinical reasoning, you do experiments with your friends, this and that. Now, time mode practice is very important because a lot of new questions and tough type of questions that might take away. so much of your time. So very, very important this time, because 3.5 hour is not a 1 hour exam, guys. How when half exam goes, you are totally lost. We all felt it. I mean, we have also been through this, right? So, I mean, in halfway, it's very different. You need to be physically and mentally fit. So I'll recommend you guys, I mean, just don't keep yourself like, eating and sleeping and studying. Also become a little bit physically fit, because you have to study, like, you have to sit for 3.5 hour, not a matter of joke, actually. All right, please keep it in mind, actually. So maybe along with your studies, a 30-minute, at least walk and stretching is highly recommended, actually. Again, indigenous health and AMC current, keep checking the website about the announcements and this and that, actually. So already, this is the basic 150 question you need to mark. I mean, roughly you have to get half, but now you have to give even more. Then this is like 3.5 hour. CAT means computerized adaptive test. They can monitor your, yeah, they can monitor your um, answers and the pattern. Actually, how can you start practicing? We will organize those actually for you, so don't worry. Okay, and the Pearson, like, you can see the centers, any nearby centers, take a date, try to take like a appropriate date. Okay, so these important things. Yeah, few changes, like, I mean, structurally not huge changes in these exams, actually, not in the marks, actually, but lot of new questions what they are trying to do, actually. Our all of our target is this, actually, getting after registration, actually, the general registration. Eventually, initially it's professional or limited. At the end, after working in Australia for 1 year, then you can apply for the general registration. When you get the general registration, you can apply for the PR. Is it clear? This brings us to the last point, doctor. What is this, things about registration? See, many doctors knows after MC part 1 you can get a job, actually, but it is not that easy. You need to have an outstanding CV. Everyone is just coming and like, let's say, doctor, is it guaranteed after MC? Like, how come it can be guaranteed? Actually, if you're exceptional, definitely you will get it, but you need to keep trying. And then another dilemma comes: should I go for the MC part 2 or just keep trying for after the MC part 2? That is another dilemma at the same time. So understand that, you finish your MC1 and you apply, job will not come immediately. I've seen doctors after finishing part 1, they got the job after 2 years even. All right. So you can see that, like, recently, there's a one doctor, she got the job. I mean, I posted Dr. Niharika. I mean, very close. She got this job after 2.5 years, I remember, after getting finishing the MC part 1. In between that, she was initially trying for the job, then it was not working. Then she finished the MC2, then applied for the job. Now she got the job. Okay, so this is a dilemma at the same time. Is it clear, guys? Like, where you all will start that, MC1, now you are applying, you are not getting the job. Should I go for MC2 or should I just keep trying, actually? That's a gamble, guys, actually. But if you have outstanding CV, let's say 3 year, 4 year, 5 year of experience, also experience in emergency field, some people also have experience in Australia for 1 month. Now you're a good candidate for the job after part 1. Some people also migrate from the home country to Australia with a master's course. Maybe their partner is taking a like master's course and they are going there, just to increase the chances. Okay, so this is probably one of the last resort we say that, you can also, when things are not happening, you make things happen, actually. Because once you get a job and establish in Australia, you paid really, really well, actually. And all the hard works, all the amount you're investing eventually paid off, actually. So thing is, the soon you can get into Australia, it's better, actually. So if any of your partner may be clinical, non-clinical, in that way they can also get into Australia. Let's say a nutrition course, a health management course, any other thing you can take or your partner can take, actually, which is also PR listed. So another way you can also apply for the PR in that way. Is this information so far helpful? Let us know in the comment section, guys. Is this information so far helpful for all of you? Okay, let me know in the comment section, actually. All right. I'll take 2 minutes for WBA thing, actually. Okay. First of all, we have a video in our YouTube channel where I was taking MC Part 2 class, and there was a one doctor who was attending, even though WBA program is different, but it is quite a similar to MC Part 2. Okay. So WBA program is like you have to get chance into the program. Okay. But you have to be already inside Australia working after MC1. Then you get matched with the WBA. Then you go to the WBA program for 1 year. There will be rotation. There will be small, small exams. Then you cleared it. Then you get the general registration. Then you get the general registration. Someone asks, does PR holders? Yes, definitely. If you're inside Australia with PR or without PR, you get some advantage. Yes, but that's not the everything. You still have to crack the interview. Some people, when they go to interview, they vomit immediately. It's not gonna work actually. So first of all, if it's very close, you understand my point, my dear. If interviews are very close, like okay, this candidate looks good, or this candidate also looks quite good, in that case, the whoever has the peer in between the close, the one with the peer get the job. But one person going to the interview and talking like a lost or rubbish at the same time, because many people get scared in the interview actually, and then they're like speaking is not fast, and at the same time they keep talking here and there. I'm sorry, they're Aussie, come on, like there's pronunciation things you at least have to understand. Then how you deliver, how is your pronunciation, it's always does not matter, but at least you have to understand like what they're saying actually. And if you keep saying like sorry, I didn't understand, one time, two time, three time, but they will think, okay, once the patient will come, what this person will do later. Then they keep working on English. A lot of people I saw, over the time, initially they're not getting job just because their English is not good. Trust me on that one, So, and English doesn't mean you have to be like a native speaker, like an Aussie or like a British or something like that. It's not like that actually. It's just a clear English tone and your ability to understand what they're saying, during that interview as and explaining a case, so that things are more important actually. And you have to be smart at the same time. All right. Is it clear, everyone, that getting that registration thing and working in a WBA program, you already have to be inside Australia. Sitting in our home country, you are not eligible for WBA workplace based assessment. There are some job available in the regional areas. That is not WBA. That is actually you are applying regionally after MC Part 1 or MC Part 2, getting a job as a medical officer, getting a job as a GP. GP, by the way, I mean, there is an interview exam that is called the PESCI exam. Have you ever heard about this name? Have you ever heard about this name? That is the pesky. If not, you can Google it, read it more about that. Actually, it is basically it's AMC. You have to do AMC part one, and then you can apply for the job interview, and then you are eligible for the pesky, clear the pesky, and then join the hospital. Actually, okay, right. You don't have to go through the clinical in that case, actually. All right. I mean, you can go to the job by the PACE-key. PACE-key interview is also kind of like a exam, actually. Okay. There's three types of PACE-key interviews are available, or three types of PACE-key things are available. You can keep following our YouTube. There's more informations are given. Yeah, that's a GP pathway, actually. In order to join as a doctor in Australia, you don't need AMC2. Later, if it's about the general registration, you may need the WBA or you may need to go through the AMC2 or any other further way that is different actually. Okay, but in order to enter into Australia, after AMC1, you can also go to the GP route. But understand one thing for the GP route, do not think about getting a job, as a GP if you have less than 5 years of experience. I'm talking about the GP things. If less than 5 year, let's say 2 year, 3 year experience, then think about medical officer. Is it clear so far? Please comment me in the comment section. Yeah, I'm trying to squeeze things. I have a nice video in my YouTube channel. If you go to my YouTube channel, what to do after MC part one, you can search that particular video by going to my channel. That explains more because I was talking to all the past candidates actually. Now, see, there's no hard and fast rule. The more the experience, higher the chances. Last month, one of my student who got the job, she had like 9 years of experience actually. Medical officer, there's so many videos available like how to get a job. So that is the thing. It's not a job related like session today. I mean, in future you can contact us for the job related session, or you can drop me a message in my messenger. I can share you that particular video. Okay, in that case, actually, so we already have a session video we upload into. We have uploaded almost everything in YouTube. You can also check that one actually. All right, great guys. So we do have session coming up. You must be knowing actually. So, anyways, how many of you have done your very important question? How many of you have done your verification, this epic verification thing, guys. How many of you have done your epic verification already? Or it's my intel, it is called nowadays. All right, you're done. It's good. Guys, please try to help each other in that case, actually, especially in the batches. There are some doctors, they need little help. So please help each other if you can, actually. It's not a like always necessary, but it's a complicated process. So normally one candidate help other candidates, especially those are in the batches, actually. So verification, MC account making, MC part one, then you go for the MC part two or the WBA, finally the after registration. In between, you can just take a shortcut. You can go to the GP pathway. Is this clear so far, actually? Summary again, no structural change in the exam, but the bar has increased. That is the summary. All right. For 1 minute, just probably showing my face. Yeah, just to switch over the screen. Yeah. So more things in the coming days, which I'll be talking with our doctors, especially about the Aboriginal and the things changes, is more like a intensive things, actually. Aborigine, Torres Islander related more topics we'll be discussing in coming days, actually. Here's few change already I mentioned, how to tackle this and that. And now you see the Aboriginal involvement. Aboriginal related a huge file, I have prepared for you guys, actually. So, I mean, one thing I'm showing, I mean, those of you came for the, this summary session, actually, but there will be more longer session in the full course, definitely. Uh, Guys, those of you can answer, some of the candidate answer, like how long it takes, like a epic verification process. Please feel free to answer them. Will be really nice, guys, actually, if you can just help them a little bit. All right. Because some of you already done it, actually, because we're into this. Now, here's a simple prediction for this is like highest areas, cultural related. There's a chapter already in John Mottag regarding that. Anti-racism is new, so we have to add more notes in the SMA note regarding this. Um, um, Elderly abuse or domestic violence. All right. So this kind of topic, trauma related, see trauma and emergency related thing questions are increasing. Now it will increase more. Emergency surgery related question, they will increase more. This is another thing. All right. But what type of question, this and that, which I will be talking definitely with our candidates in the coming days, actually. Chronic diseases, they are emphasizing a little bit more. Let's say CKD, let's say diabetes, let's say HIV. So this kind of disease related, things should be more, actually. All right. Rheumatological things, I think, always been quite a favorable. Yeah. So you can just keep checking. We already had a rheumatology class, you can have a look on that. Um, but rheumatic, like heart disease, so the cardiac and rheumatic heart disease, because it's more related to, again, those aborigines, actually. Okay, aborigines has this particular problem more. So that's the thing, actually. All right. Uh, Next is a like a hearing loss in Aboriginal level. So again, that part, we're talking about this Aboriginal a little bit more, maternal and childhood. Already there's a chapter there in John Morton, but I think you need to study a little bit more from some RSCGP guidelines, which I will guide you guys even more. All right. All right. So again, let's say court order, trials, patient's autonomy, medical ethics related more classes would be important. We have classes on medical ethics, but I think we'll take extra classes on ethics in coming days, actually. All right. So, anyways, guys, I mean, these are in general, but I think you are getting some ideas. So, these are few Aboriginal related thing, but emergency related thing. There will be more additional things which I'll be discussing in coming days. There'll be like few things related to hemato infectious, which I'll be discussing in coming days for you guys, actually. All right. So, anyways, let's get started with our GIT, guys. Are you guys ready? Yes. Yes, for the session. Thank you so much, guys. Those of you just attended for the updates, thank you so much. I mean, we are getting into the class now. If you want, you can go through this particular session. Yes, I have added new questions with the last file. Yeah, so this is our academy. If anyone is interested, you can leave us a message in our messenger, or you can save this WhatsApp number directly hotline. It will come to me and my team. So this is my WhatsApp number. If anyone wants to save it, you can save it actually for now, actually. Okay, now it's time to get back to GIT. GIT, we have a theory which is posted already in YouTube. You can check. And also for the doctors, which is those are in our course, they have already attended. And today is the recall part. We were into the Eid break, actually, Eid ul Adha break. So we are back into the break. So we're feeling refreshing. And I just put my WhatsApp number in the comment section, so you can just have a look on that. Actually, I'm just also putting it one time on my screen so that if anyone didn't have it, can have it one more time. So if you WhatsApp in the site, it come to me or my team directly, actually. All right. So any of those inquiries, if you have further, you can WhatsApp regarding this actually. All right. You may also get chance to talk to me, if the team couldn't answer something actually. Yes. All right. Yeah, thank you. Yeah, do not call us late night. It would be nice actually. Yeah. It remains silent in any way. That's okay. Thank you, guys. Going to the first question, let's get started. If anyone didn't save the WhatsApp, that's thumbs up. New questions, fresh questions blended with the last class. Actually, so I think the half of the file has been changed again in just 6 months, actually. All right. Now, a 12-year girl with a difficulty in swallowing and on PPT showing moderate eosinophil inflammation and 15 eosinophil on biopsy. This question came at the last year end, by the way, and a very interesting one actually. We collected in last November. What is the next step in the management? Come on, guys, it's your time now, so let's go for it, guys. First, you have to make a decision that what is the diagnosis. Very important that what is your diagnosis here actually. Any idea, any guesses what is the diagnosis is? So there's a first of all, it's indicating dysphagia. Certainly, it's dysphagia. Eosinophilic inflammation is the so this is the diagnosis EOE, right? We read last day about this thing as a theory. So of course, so in this particular case, actually, so diagnosis is eosinophilic esophagitis. Now, if it is a eosinophilic esophagitis, what do you think is the what is the next step in the management? What is the right one in case of this? All right. So the right answer is eosinophilic esophagitis. Your answer would be going for a first of all, if any particular thing is causing it, you stop the offending agent. But nothing has mentioned in this question as a stopping offending agent. So our next step in the management is actually a steroids, which is the eosinophil, which is an inflammatory allergy condition. So you eventually need the budesonide. Now, did you remember from the theory class, did I mention about the topic steroid or the budesonide in the last theoretical class? Yes. Okay. Those ask about this six food elimination diet is an option, but Buddhism is the next step in the management among the choices. So, which one is a better actually? It's actually the Buddhism is better actually. Six. That's usually a, let's say, when we go for the lifestyle modification. I'm telling you one thing in that way. Says someone is obese, there's so many, suggestion comes in general. So the six food exclusion diet is a in generally, you can say like I think it's also given in John Mottak, like a lot of points are included there. So that's like a chart, but that is not the stopping the offending agent actually, because you have eosinophilic esophagitis, you have the allergic condition now, and next important question is it a acute? Please check the question one more time. Is this one is an acute eosinophilic esophagitis? I repeat my in question again, is it an acute eosinophilic esophagitis? Because you see 15 eosinophil, so it's an acute one at the same time. So acute one is just stopping that, general dieting thing will not work. So most Appropriate thing is definitely eosinophilic esophagitis here. Yeah, so yeah, so steroid would be the best possible thing here, budesonide or any other dose steroid actually. Great. Clear this thing? It can be associated with many allergies. Sometimes, let's say this question is not fully complete because it is recall. Some question also say their family history of allergies, this type of points. Some cases they mention that when they eat, drink, or eat something like peanut, then they have this kind of problem, or any specific food, and that specific food is given in the question option. Then that has become the main step actually in that case. Like let's say if a nut is causing that main issue, then stopping the nut is number one. So six food exclusion is a general, some cases when diagnosis is not sure. I'm telling it, some cases when the diagnosis is not sure, then we also give this food exclusion chart. When we stop them, then we get to know, okay, maybe this is how it works. This kind of thing also available for celiac disease and other things. When you are not sure with the diagnosis, so some kind of exclusion chart we give, and then the patient improves. Oh, that's the diagnosis. Now is it clear, everyone? So now here we can see it's already eosinophilic esophagitis. There is no such doubt actually. Clear? Yes. So summary answer, taking a little time, but eosinophilic esophagitis. We have the both thing. One is on left hand side, some notes, IgA elevated, eosinophilic infiltrates in esophagus. There's multiple constriction. Is a special line you want to add. The endoscopy will show there will be multiple constrictions. This is the extra line which is not written in John Morta. Another thing is a like budesonide specific for this condition. It's not written in John Morta, but you can also add that one actually. Yes. All right. Great. So summary here, six-food elimination diet is a popular diet for eosinophilic esophagitis also mentioned, but that is more popular in terms of making the diagnosis and all these things actually. But when it's an acute case, when you have the 15 eosinophil, it's better to go with the steroid therapy. Steroid therapy initially, and then in generally that particular chart. Because is it a short treatment or is it a long-term management? You need long-term management, right? So initially you're giving the steroid to reduce inflammation, and over the time you give a six food elimination chart so that it does not aggravate. Now is it clear? Final thing? Yes. Yes. Yeah. So I double checked all this thing not only from the John Morta, I also checked these things from the BMJ, which you probably know. BMJ is one of the best journal in the world, actually. So also double check that one, actually. Yeah, so this two double checking is, I mean, I have been done. I was also confused with the six food or this one. But six food more, it's like a bit later. Next question. Sorry for taking a little more time. 36-year-old with a heartburn after meal and night regurgitation, no alarming sign, but it's a clear cut for you. So initial management. Now this time they have cleared you. They want a initial management, not a very specific or appropriate one. So in that case, first of all, let's go with the diagnosis. I think all of you would be agree because it's mentioned nighttime, ear, heartburn. So going it's certainly with this popular condition ZERD, and if it is a ZERD, certainly it is a trial PPI. That is very, very important. So PPI with a lifestyle, but I'm not finished here yet. So I'm going to tell you two more things which is also tested in AMC. So AMC important tips for ZERD. Often you will be given option. Is it PPI or is it an barium investigation? PPI or barium investigation? Now, question is for the ZERD, do we always go for barium? I mean, we can see if like obese person and that I'm having bloating, I'm having night symptoms, when I sleep, I don't feel well. Are you going to do barium or you'll give the PPI? You will give the PPI actually, right? So the initial treatment or initial approach is not the investigations. The initial approach is PPI. Okay, Please confirm in the comment section, is this information is clear to you? I gave this information in the last class in the theory. Guys, you need to be a little bit more supportive during the class. Yes, clear. Next one is another one which is very popular in the exam. They will be telling you, okay, treatment is failed. You are trying with a 20 milligram and treatment failed. What to do in that case? Going for more investigation or increase the dose into 40? Answer, increase the dose into double the dose. So double the dose, this one is like popular. Double the dose related, more questions we will find in future. Actually, not only GERT, but many other conditions. Like let's say in future we'll find the asthma. Asthma, we double the dose, and this is the thing. In this case, it is GERD, gastroesophageal reflux disease, my dear. I mean, short term is GERD. So it's a acid reflux because of the relaxed sphincter. If anyone didn't see the last class, there is an acid reflux thing happens actually. So we go for a trial PPI. Now, is endoscopy is a choice. Now we have the test like barium, that's the main thing. But do we do the like endoscopy all the time for because dysphagia or these things are not present at this point? Actually, see, they said heartburn, which is the number one feature. They said ninth symptom, but they didn't mention anything about the dysphagia or any weight loss. If dysphagia is present with GERD, is it a red flag? I'm asking this question. Dysphagia present with GRD, is this a red flag? Yes. If it's a red flag, means it can be cancer by any chance. So then we go for the endoscopy. This is another popular question. So this thing is another popular thing. So endoscopy, if alarming features are present. These are some of the alarming features actually. Dysphagia, weight loss, GI bleed. Some of anyone here having ZERD? Anyone here having ZERD like feature? I mean, because we are doctors, we are eating, we have to, we have so many sleepless night, right? Caffeine is, I think instead of saline, I think, we can also take caffeine. It's kind of like that actually. All right. So, I mean, we don't have a choice actually, instead of like coffee, this and that, actually. The tea all the time, coffee all the time, I can even ask a poll like, tea or coffee, what do you like? Anyways, avoid large meal at night, guys. Whatever, even if you're working at hospital, I know you're hungry and this and that, but try not to eat. A lot of doctors like at 12, 1, they are eating there because busy with patients actually. Yeah, someone said a very nice one. I liked it. Find doctor with ZERD. Okay, good one, my dear. Okay, very good one. Late night meals because we all have duties. Okay, caffeine, alcohol. Alcohol maybe we're not taking, but caffeine is there actually. Yeah, someone give a nice take ice water. I mean, the early you finish, it's better. Yeah, that's the main thing actually. And eat clean. It's also better. Ready for next question? Yeah, sorry for taking a little more time in the first question. I'll be more faster in next one. 45-year has epigastric pain and positive urea blood test. It was a very popular question. It has been tested all over last 1 year. So very high yield for our AMC this year actually. Actually, this year already it is tested already one time. So what is the next step? Urea blood test positive. I'm getting little smell about this peptic ulcer disease because of what? Because of this culprit H. pylori. Okay, so this H. pylori culprit we have to eliminate by a triple therapy. Right, this is the John Murtagh line you will find in the John Murtagh. I'm giving the page number so that you can check any time later. Already we have gone through the theory. If anyone coming to the class first time, we had a full theory on GIT. Please check in the our um, YouTube channel, Share Ahmed Shujar Medical Education. You'll find that one actually. Great. All right. So that is the thing. So here is the thing given is as a triple therapy things. Extra thing on AMC, some cases they give two question to see the prognosis, and one is a treatment failure. Guys, do you mind if I tell you the extra things which can be tested or tested already? I hope I don't. Okay, so they will also ask you now. This question is about the treatment. This one is about treatment. Another question about prognosis. Okay, urea is one time positive, now triple therapy ongoing. How to see the prognosis? So how to see the prognosis, guys? Tell me, come on, guys. How to see the prognosis? Again, the same thing. Urea breath test. Again, the same thing. Urea breath test. So urea breath test is a test diagnostic and prognostic. Let me clarify. Urea breath test is a test for detecting H. pylori. Detecting H. pylori. It's a diagnostic test and also prognostic test. Diagnosis confirmed with H. pylori, urea breath test. How the triple therapy working or working or not? Again, urea breath test. Clear now? Yes. Okay. Now, you give a treatment and the treatment is failed somehow. This can happen. And if you're living in Bangladesh, India, Pakistan, even more higher chances because you know tell me one thing, guys. Is antibiotic is easy in your country? At least in Bangladesh, it's quite easy. I mean, I can just go downstairs. I'm a doctor, but it's a different. But any person can go downstairs and buy the antibiotics. So easy here. Anyways, so I think in India at least it is difficult. At least getting those antibiotic without doctor's prescriptions. But actually, at least still you can manage, but difficult actually. In Australia, impossible. Like you get antibiotic actually. All right. So one tip here, guys, secret small tip. While you go to Australia, other than many of your clothes and this and that, take some antibiotics. Sometimes you feel like you know that there is acute otitis media you are having, but still the doctors are not giving you antibiotics. You must be had these things multiple time actually sometimes. All right. So, anyways, take some antibiotics with you just for because you know it that that you are sure that there is something. All right. Coming to this one, so metronidazole is a drug that is commonly getting resistant. Am I right? Yes, because that has been misused a lot. Yeah. Good question, BTW. Can doctors prescribe themselves in Australia? Unfortunately, you have your own GP, my dear. Example, I have, uh, the last time I was there, I have my own another GP. I cannot prescribe myself. All right. Yeah. Now here it's not like doesn't matter. I go to the shop and okay, give me these drugs and this and that. Oh, doctor himself came to the shop. That is how they treat in the pharmacy. In there, it doesn't matter actually. Yeah, it's a very basic thing in Australia. Every area there is a registered doctor, no matter what are you. Because otherwise, you might be involved in criminal things. So everyone have a doctor in Australia. Even if you're a GP, your physical health, mental health, the job is not yours. The other doctors. That is one of the reason. Do you agree on that point? We doctors are worse patient in our country. Agreed on that one? It is true, actually. We doctors are also, we don't listen to anyone. But for even simple thing, for your mental health, physical health, you have to go to your GP. Even he's a doctor, you are a doctor, that's okay. Yeah. He will monitor you that, you are not thinking to things too aggressively. I mean, you can talk to him that, based on your clinical things, but he will, even if it's there, like, he will not give you antibiotic. Even if you're a doctor, he will not give you antibiotic. All right, guys. Yeah. So, anyways, there will be a GP, there are Medicare, there are like a lot of things. Anyways, so treatment failure case, in that case, you have to change the metronidazole and give another combination. This is another popular question regarding this particular peptic ulcer section. Please mention as it clear so that we can go to the next segment. Guys, are you enjoying so far? I mean, I hope it is. Uh, next one. GIT is fun. Yes. 70-year man, this time old, with a melena. Melena means lower GIT bleed. Okay, now endoscopy revealing. All right. Now, melena can be upper GIT bleeding. I'm sorry about that. Fresh bleeding would be lower GIT bleeding. Melena is the upper GIT bleeding. Okay, endoscopy revealing duodenal ulcer with a bleeding edges and biopsy. I mean, that's quite a information given here. Biopsy confirmed that he is H. pylori positive. Okay, endoscopy and biopsy. What is the appropriate next step in the management? I think this was there in our theory class. Agreed, guys? Okay. If you know what I'm talking about, then try to answer this, my dear doctors. It was there. I remember. I can tell you even the page number. Can you tell the title topic? Then some of them can understand. What was the title topic of this one? Is it a lower GIT bleeding, upper GIT bleeding, or what was the title topic of that one? A lot of people are answering because based on this, like H. pylori positive, and if it is a H. pylori positive, a lot of people, I think, a little bit uh, towards this. Remember last day? What is it? It's bamboo, right? Sometimes we make fun. What you were expecting that is not happening. Now, H. pylori thing, it is true and it is given as a distractor so that you pick up the triple therapy. Now, even if you get triple therapy, will it work like a magic drug? Is it your first priority that, controlling the H. pylori at this point or controlling the bleeding is your first priority? Please check it properly because most appropriate step is being asked. So controlling the bleeding is the first priority because of bleeding, the patient can later they can have serious issue. But because of peptic ulcer, patient will not die for sure, right? And it will take some time to get rid of H. pyloris. So the final answer here is a it's a bleeding peptic ulcer. If you remember the topic, yeah, here was the topic. Bleeding peptic ulcer was the topic. They give H. pylori on the top to confuse you. This is how MC keep changing the question all the time. Similar kind of topic, which will be happy. Oh, doctor, that's the same question, but why I didn't pass? Yeah, because you didn't see the, yeah, it's H. pylori and you jump for triple therapy. But that was the question. So did you understand? What they mean by this is the classic clinical reasoning question, guys. This is the classic clinical reasoning question. Clear, everyone? What they mean actually by the clinical, more practical approach. Patient can have two, three conditions together. Am I right, guys? Originally, when we see a patient, does patient have one, doctor, I have a peptic ulcer disease? No patient come in that way. Patient came and tell, I also have that, I also have this, I'm feeling, I think, I also think this. So many things they say. So they're trying to be more classical actually this time. So, all right. I remember one time, very early days in internship, I went to a outside Dhaka and I was trying to make a diagnosis. And someone came like 70 years. Why you are taking so much time? I look at him, what? If you take so much, just give me those vitamins. Because it's a government hospital. So I understood it's not a real case. So he came for vitamin and iron, basically. Anyways, yeah. So summary thing is here. This is bleeding peptic ulcer, injection adrenaline. Last day we discussed this thing. John Murtagh, check this thing as a reference later. Or check the theory class again if anyone didn't see that one. Next question. Okay, switch over. It says the topic. This time again, elderly 64-year with a new onset dyspepsia. Guys, dyspepsia is a separate chapter in uh, John Murtagh. A lot of people skip that chapter, but I found questions started to come. So this question I kept from the last batch class actually. Okay, because dyspepsia often you guys skip. Now he reports unintentional 5 kg weight loss. He has no prior history of peptic ulcer and I know what is the best management, next best step of management. The question, topic is dyspepsia, not really dysphagia, dyspepsia. Now, this thing with dyspepsia and weight loss, so can I say in that way, this is dyspepsia with red flag, okay? Can I say this is as a dyspepsia with a red flag? See, there are dysphagia with red flag, dyspepsia with also red flag. Okay. In both of these cases, what we can do, because it's been red flag, so chance of cancer or suspicion of cancer, so that is one of the reason we go for gastroscopy or endoscopy. There's two risk factors. One is age, more than 60 alarming feature, and one more thing is a weight loss. Okay, so two factors here, cancer chances. Right? Yeah, it can be a esophageal cancer. Yeah, yeah, yeah. Gastroscopy, endoscopy, you can like, in a similar way you can think. Alternatives. Yeah. Those of you who are still not sure, I have information for you. Yes, you can see. So unexplained weight loss, this is one of the thing. Also, you can add the age from another book reference, the age and the investigation of choice. Now, are we full sure, guys? You can check 450. Like, so I always mention one thing, guys, very important. First reference you try to take from the John Murtagh. Then come the other websites like, or other textbook like Davidson, this and that. Then come the all the websites actually. I mean, while you preparing, always keep this thing in mind actually. Okay. Next. 23-year woman presents with persistent bloating, weight loss, and some labs are given with a microcytic. So young female with microcytic anemia, likely diagnosis. Looks very easy and silly question, but I don't know, but they give this question very often in the exam. So bloating, fatigue. Fatigue is a see fatigue often you ignore, but always remember my word. This fatigue is somewhere related to a lot of chronic diseases. Before going to the final diagnosis, can you say what diseases it can be? This fatigue thing. Okay, like a celiac. All right, celiac disease, CKDs. But age is not supporting here. But generally, I'm talking about fatigue. Then diabetes cases, right? Then things like MS cases. So many other neurological condition and even a lot of vitamin deficiency cases, fatigue, right? Many autoimmune cases as well. Well done. Thyroid cases. Okay. So many things started with this word fatigue. So do not ignore the fatigue. If if the patient is telling for longer time, I'm feeling very weak and fatigued. Okay, now microcytic anemia, this one is going towards, yes, please. This is going towards the celiac disease actually, because the anemia, the weight loss, fatigue, bloating, these are indicating towards the, yeah, celiac disease. And in Australian prospect, in Australia, see, is Australian or Aussie women, are they like Asians normally? I'm just telling in generally, respect to all. It's just typical Aussie people, they are quite big in size, actually, and physically very fit, and they go to the sun, they run, they're very up to date with the nutrition. So, in terms of this anemia thing, which is very common invariably in almost all women in our countries, you know, is it that common in Australia? Not really. Even their bone mineral density is also quite good in Australia. A lot of researchers has shown actually, unless genetic. All right. So in this one, rather than the iron deficiency anemia, if this thing would have been an Asian woman, I would have been think first as an iron deficiency anemia in these cases because of microcytic anemia. But from Australian context, actually, I think I'm thinking more about the celiac disease. Even though it's a recall, even though it's a recall, uh, I'm expecting maybe main exam will also tell you few particular things related to diet as well, right? Means few particular dietary things actually. Yes. So bloating, weight loss, iron deficiency anemia, that's a triad. John Muttak has a lot of triads you will find actually, guys. So this is also a triad. So it touches all the triads actually, guys. And also a young person at the same. So iron deficiency anemia versus celiac disease, you should double check, triple check. That would be, these are the things you need to be master on actually. That next time if this question comes, is it iron deficiency or celiac? How would you differentiate one by one actually? Right? Now about celiac disease, I mean, what is missing in this question actually? That some particular food they didn't mention, right? Like if you remember, I mentioned about something brown, right? barley, rye. This rye, not rice. Rye, oat, and wheat. Okay, so you need to avoid and yeah, some of the yes. One more thing, if classic iron deficiency anemia, is it associated with weight loss? Another thing, guys. Is classic iron deficiency anemia in female nutritional deficiency, does it associated usually with weight loss? Usually answer is a no. And in this question, the cancer thing is not given. Iron deficiency anemia with weight loss, we can also think about certain cancers actually. Okay. But considering the age group, we'll eliminate the cancer at this point actually. All right. Clear? No, celiac disease. So there's some blood tests, there's some duodenal biopsy to confirm. This is very popular for the exam. Lastly, we also mentioned a small bowel biopsy or duodenal biopsy. This is like a normal villi, but if there is celiac disease, there are more flattened villi. Remember? And that gives rise to malabsorption. That gives rise to malabsorption. And the clinical features, if you see bloating, weight loss, iron deficiency, anemia, these are the classic one. Lifelong gluten-free diet, that is the mainstay. So, summary picture again. Healthy villi, good for absorption. Flattened villi, bad for absorption. Is it clear about the celiac disease, guys? We have read celiac diseases already. Yes. Here is a link which I took. Nice. Are you familiar with NICE guideline, guys? I mean, we keep talking all the time about the RSCGP and RSCGP, but I think in the MBBS, I mean, we all go through the Davidson and a lot places mention NICE guidelines actually. So guys, you can also check the NICE guideline. It is also fine some places actually. Yeah, because these are very good, like NICE guideline, PMJ, these are top class in the world. Even Davidson book is made a lot of guidelines for NICE guideline and BMJ, yeah, NHA's guidelines, yeah. Anyways, few more things. So initially at the blood tests and more accurate is a small bowel biopsy. This is another textbook reference. Oh, next question. A man developed epigastric pain shortly after eating in a restaurant. Okay. So restaurant related issues. He has a past history of anaphylactic shock after eating carrot cake. Now, carrot cake related this question recently also came up, so I kept it. Carrot cake related this question also came quite in past as well, actually. Carrot cakes are available in a lot of places. Is it tasty? Has anyone tried the carrot cake? Correct halwa. I mean, I'm sure you know what halwa, right? Is that sound very uncommon actually? Yeah, I think in our countries it is common. The carrot, yes, but in the yeah, yes, someone said yeah, gajar, yeah, yeah. We said so. Anyways, in uh, there are shops like 7-Eleven shops, right? And there are like petrol stations in Australia, if you have seen. In that one, so many those carrot cakes are available. Try it, very nice actually. And this carrot cake contains actually nuts, eggs, and that can gives rise to these allergies. If allergies become serious, this anaphylactic shock is nothing but an allergy, but it is a severe form. Okay. Now the question is, what inside that carrot cake can leading to this thing can happen? Some points are given: egg, then milk, then gluten, then carrot. Certainly is to not. See, celiac disease will not be like that much shock. Okay, this malabsorption mostly. So it's not celiac. So in between these two, one you have to pick up, and that's the egg. In Australian context, you can search with egg allergy this thing. Okay. There's another question in AMC other than this egg allergy come in AMC as carrot cake. All right, there's another version uh, with the vaccine actually. And which vaccine? MMR vaccine. A lot of people has a believe like MMR vaccine has some relation Okay, if you give MMR vaccine, has some relation with egg allergies. But is it true? MMR vaccine and egg allergy. Perhaps this question related to immediately after eating. If someone has allergy, like immediately it is started uh, with the egg allergy. Now we're talking about another thing that, MMR vaccine, is it possible some relation with the egg allergy? Taking 1 second. Next question. Like those have egg allergy, can they take MMR vaccine? That was actually the question, one of the pediatric question. Those have egg allergy, can they take MMR vaccine? That was the question actually. The answer is a yes. Even with egg allergy, can take MMR vaccine. Safely can receive MMR vaccine. Reference Allergy Australia. There's a website in Australia, allergyaustralia.org. You can check. All right. That was a different question with the MMR vaccine because it has been tested. In this question, let's focus on this question. Eating the carrot cake, and the carrot cake is containing egg. Carrot cake probably also containing nuts. So either of them can is causing this particular anaphylactic condition actually. Usually there is a special line, uh, how we counsel the mother. There's a MC part two, one of the station is this, that there's no relation between MMR vaccine and egg allergy. That is how we explain. Okay, clear now, everyone? This is a very popular MC part two question, and we counsel the mother in that way. There is no relation between MMR vaccine and the egg allergy. I mean, mother has concern like, if you give MMR vaccine, will there be egg allergies, this and that? No problem. Okay. Allergy related questions are popular in MC. It is true. Anaphylaxis related questions like angioedema is also popular in the main exam. So I brought some of the extra thing. Uh, would you like me to review them? Yes. So urticaria, and there is a thing, angioedema. So mild, moderate, severe. Okay, so a lot of way it can be given. Our last case, um, they mention anaphylactic shock considering serious. Serious, we understood in that way. So serious, we understand there will be chest symptoms. One thing. That is clear. Severe means there will be chest symptoms, and usually we give IM adrenaline. These things we consider in this way, like IM adrenaline. And earlier cases means mild to moderate cases. What are the treatments? Earlier cases, especially mild, in mild cases, the treatment is simple antihistamine. In moderate cases, we give the steroids, prednisolone. And in severe cases, is IM adrenaline. IM adrenaline only applicable when life-threatening. IM adrenaline only available when chest symptoms are present. Chest symptoms are present means it is life-threatening. Okay, so summary thing, serious reactions, IM adrenaline. This is extremely popular in mainstream exam. Great. Ready for next one? 52-year-old with going through epigastric discomfort despite initial treatment. Okay, what treatment they didn't mention anyways. And upper GT endoscopy is normal, no ulcer, malignancy or esophagitis, no alarm features, basic blood tests are normal. What is the best ongoing management? Okay, I think it's not difficult to answer this one. Best ongoing management approach in this case. Endoscopy findings are normal, no malignancy or anything noticed. Okay. Did you know or did I discuss last day there's something called functional dyspepsia or non-ulcer dyspepsia? There are certain terms like functional dyspepsia is one thing, then there is a non-ulcer dyspepsia. This brings us to one of the MC question. Which type of conditions are more common? Yeah. What is the most common one? Is it a duodenal ulcer, gastric ulcer, non-ulcer dyspepsia? Which one is a MC? MC means most common. This is how they also test you based on population health. Answer is a non-ulcer dyspepsia. Non-ulcer dyspepsia actually the most common. Like even many of us probably have this sometimes gastric irritation. Do we have ulcer? Not really always, but it is non-ulcer dyspepsia, but not a classic duodenal ulcer or a gastric ulcer. I hope that is clear to all of you. In those cases, also treatment like GIT, like PPI and lifestyle modification. Yes. Next question is coming. A patient is a known case of ulcerative colitis. Okay, they already mentioned it is a IBD. IBD is very popular in AMC, by the way. With distension, fever, toxicity, imaging confirms toxic megacolon. They might give you the megacolon, imaging like CT. What is the next step in the management? Yes, please. So good news is they already clarified what is the diagnosis. Keep going, guys. Just taking a second. All right. So will the answer please? All right. Um, there's a doubt. Some people are thinking as a high dose steroid. Now, question is high dose steroid. Can you control the toxic megacolon? Is it the right approach at this point? Ulcerative colitis confirmed with toxic megacolon. Is it a complication of ulcerative colitis? Okay, let's see first what are some of the yeah, this one I hope you remember from the last class. Left hand side is ulcerative colitis, and this side is Crohn's disease. Initial some features, GIT, extra GIT features. Among them, uh, complication is a toxic megacolon. When ulcerative colitis with distended bowel, it is suspected as a toxic megacolon. So they said it is ulcerative colitis, so we'll suspect the toxic megacolon first, whereas the fistula uh, and obstruction, those are more common with Crohn's disease. Okay, coming to this one, this as per the NICE guideline, colectomy should be considered early in patient with intestinal, any perforation, hemorrhage, or toxic megacolon. It is the exactly line I took from the NICE guideline. Okay, some people are with the option colonoscopy. Let me clarify that one. Is it safe at this point if toxic megacolon or any other thing, obstruction by any chance, because it is associated with abdominal distension, it can be toxic megacolon or intestinal obstruction. Is it safe to go for colonoscopy? Absolutely no. Okay, toxic megacolon, is that a small bowel like issue or a large bowel issue? Let me clarify. Someone asked me, why not NG tube? Is it related to large or small? If it's a large bowel, is NG tube your priority or not? If it's a large bowel, is that a priority? It's a priority for small bowel. Clear now? Yeah. So clear now? Yes. See, toxic megacolon is considered as an emergency, right? I repeat my thing. Toxic megacolon, is that considered like any obstruction or um, toxic megacolon or obstruction? Is it considered as an emergency? Answer is a yes. So going with a high dose of steroid, will that be enough? You cannot solve the emergency. Clear? You need surgeries at this point. IBD, which is a relapsing all the time and recurrent, already we discussed earlier. So this part is for confirmation. Inflammatory bowel disease, IBD. Treatments options are given. I think checking from the John Mortag, it's better. Yes, but I think few complications like fistula, megacolon, cancers, obstructions, you need to consider. I think you can given like, yeah, they ask what is the best step. See, first again, I'm clarifying this thing. Are we dealing with in this question the best option or the most important option, or are we discussing with an initial option? We are discussing with a what is the most priority here, most important thing here, the one that will save the patient's life here actually. Okay, so yeah, antibiotic you can give initially, not a problem, but I think the again most appropriate is a urgent colectomy. I hope that's clear. It's an interesting question, last one. And these two charts, like, yeah, these two are continuation from a textbook actually. That ulcerative colitis, Crohn's disease, very interesting. Ulcerative colitis less common in smokers. So those are smoker by any chance have a good news. as a fun, so as like Parkinson's and some of the dementias. All right. So if anyone smokes and this and that. All right, guys. So IBD is popular for AMC for very certain reasons, and learn the differences between ulcerative colitis can be tested very separate conditions, especially one of the line that is very popular, often given in past area of friable mucosa. Okay, and your diagnosis of ulcerative colitis. This line was very important. Something presented because thick bowel or very narrow lumen for Crohn's disease. So there is more chances with obstruction and the fistulas with the Crohn's disease actually. Ulcerative colitis on the other hand, uh, the bloody diarrhea, blood mucus, very common actually. Crohn's mostly diarrhea, and also check the location. Crohn's is also transmural, means if these are explosive layer, all four layers are involved actually. Whereas ulcerative colitis, mucosa, submucosal. That is one of the reason. Since it is transmural, your lumen get more narrow over the time and more chances of obstruction. So complications are more common with Crohn's disease, honestly. And the dangerous complication for ulcerative is a toxic megacolon. Also, keep it in mind, adenocarcinoma. Uh, Check from the John Murtagh about mild, moderate, severe treatment of IBD. If you remember, I mean, anyone, early cases, moderate cases, severe cases, anyone remembers it? So the managements, okay, sulfa, MTX, uh, azathioprine. Yes, you can also give steroid if there is any acute flare-up at the same time. So mild, moderate, severe. Sulfasalazine related side effects, let's say if it's given in a male, there can be azoospermia. It can also have effect on the bone marrow. Anyways, remember that. And also check from the books like about the recurrent cases of IBD, what to do in that case actually. Like more drug options, like I'm giving you that floor that if you want, you can read much more about the IBD. IBD is a favorite topic and popular topic. They can ask more and more new questions for the IBDs. So far, is this clear to everyone, guys? We're trying to give you explanation of lot of added things that can be useful for exam. Not only this one answer is this, that is not the practice. This is how you should study in MC in general. Okay, guys. So for enjoying, do you guys need a break, guys, here? Or two more questions, then give a break. Okay, two more questions, then let's go for a break. Which of the following has the greatest impact of development of esophageal cancer? I think last day we discussed about the esophageal cancer. Esophagus, upper two-third, lower one-third, one-third A, B. So lower one-third of the esophagus, adenocarcinoma, also Barrett's. Upper two-third, squamous cell carcinoma. The question is, which one has the greatest impact on the esophageal cancer in general? This question is more like a population health type question. It means it's more like a risk factor type of question. By the way, guys, risk factor type of questions are very important. Answer is surely clear winner is a Barrett's esophagus. We already discussed one-third AB, adenocarcinoma, Barrett's. This brings us to two more added question for AMC. Worldwide, which cancer is number one? In Australia, which esophageal cancer? So worldwide, it is squamous cell carcinoma. In Australia, it is actually adenocarcinoma. I hope that's clear. Popular in exam. You need endoscopy and biopsy to confirm the esophageal cancer surface. Often, there will be red flag. Example, dysphagia, weight loss, iron deficiency anemia. I repeat, dysphagia, weight loss, iron deficiency anemia, along with some of the features related to esophagus is indicating esophageal cancer. You see, where it's quite a high chances for leading to cancers. WOF, which of the following? All right. Anyways, one more additional thing, which is taken from the John Muther. They will give you some certain features of Barrett's, and they will ask you a prognostic question: how persistently this is this a cancer, Barrett's? No, it's a pre-malignant condition. Am I right? So it's like a double-edged sword we read in the pathology, right? So in that case, they will ask you how persistently we follow up: 6 months, 1 year, 2 year. Final answer: it is a 2 yearly follow-up. Follow-up with the endoscopy and the biopsy. Please confirm, is it clear to all of you at this point? A lot of esophageal questions in MC. Next, a 45-year-old presents with a progressive dysphagia with solid liquid is a very brand new, associated with regurgitation of undigested food and weight loss. Barium solution dilated and this and that. And yes, you see the pictures as well given. A picture showing bird peak appearance. Now, I think when they said bird peak, you understand what it is. What is the definitive management? So what they're asking, that is also important. So definitive, I think last we mentioned, if you see the word surgery and if you see the word definitive, high chances that is your answer. So they said dysphagia to both solid liquid. I think let me clarify something. Always they will not tell you dysphagia to liquid. Did I discuss this thing last day? Because initial dysphagia to liquid, lot of patients did not realize they have dysphagia to liquid. See, dysphagia to solid, anyone understood easily. Dysphagia to liquid, it's difficult to understood. So that's why a lot of patients presented with dysphagia to both solid liquid. But irony is they have started with the liquid, they didn't realize. The here thing is a given is a barium. You can see clearly there's a barium given. Yeah. So this barium is a rat tail or bird beak, whatever you say. And the main treatment is a surgical myotomy. Clear, everyone? Surgical myotomy. But some of the initial investigations or initial things you can do as a treatment, let's say, what are those? You can try with drugs, right? Like initially some drug things, CCB, then it's a narrow end. Am I right, guys? So it's a esophagus, stomach. It becomes, yeah, more tight. So you make it wide by a dilator. So CCB, then Heller's dilator, we try to dilate, but chance of perforation is high. So the best result or best actually considered is surgical myotomy. Considering even surgical myotomy, mortality rate is highest among all the procedures like CCB, dilator, myotomy. Which one has highest mortality? Of course, it's a surgery and esophageal surgery. Remember, two areas surgeons don't like to operate always. One, this esophageal area, and another one is a any cases. You can say lung, that's okay, but there's a more complicated area. Pancreatic area, so huge, so long surgeries, Whipple's, right, guys? Takes so many hours. Yeah, and many cases, prognosis, is it good? Pancreatic cancer, is it? Have you ever seen a good prognosis of pancreatic cancer? Almost very rare. It comes back after 5 years, 1 year, very quickly in 6 months. My uncle died actually of pancreatic cancer. Anyways, achalasia, we learn it's a narrow sphincter. We'll try to relax it. Very aggressive. Lung cancer aggressive, pancreatic cancer aggressive, this esophageal cancer so aggressive. The doctors are trying, scientists are saying, still we didn't get a cure. Okay. All right. A 65-year presents with a iron deficiency anemia, endoscopy normal, colposcopy cannot be done beyond hepatic flexure. Uh, Good news is the person is stable. What is the next best investigation? There is a certain bleeding out there because FOBT is showing positive. So that means bleeding is going on. But you cannot do the further colonoscopy or endoscopy. Okay, so solution of everything, small one, capsule endoscopy. Heard about this capsule endoscopy? By the way, guys, you have to return this capsule. Very expensive. It's not like you just eat, digest, and flush into the toilet. Capsule endoscopy reference is taken from the Davidson's medicine. So, see, bleeding, diagnosis of a chronic disease, which is also related to bleeding, celiac disease, some cases, yes. But if you have any history of obstruction or any sign of obstruction, you cannot give capsule. All right. So, obscure bleeding, hidden bleeding, this bleeding, that bleeding, capsule endoscopy. Okay, 50th year with a history of gastric cancer. Now, this time it is given stomach cancer, gastric cancer, and already done in more advanced Roux-en-Y, probably like anyways, like partial gastrectomy. Now, he reports after 1 hour meals, he develops palpitation, this, that issues. Now, I think we talked about it a little bit. If there is a history of gastric bypass surgery, repeat, if there is a history of gastric bypass surgery, very commonly they develop dumping syndrome. Now, if they develop dumping syndrome, there's two type of dumping syndrome, one early and one is a late. They don't have a abdominal distension feature, so it's not a obstruction, not really gastritis. All right. Uh, Not significant. So 1 hour, we are going for a late dumping. So early dumping syndrome is usually like 15 minutes to 30 minutes, even up to an hour, but 1 hour is considered late. So this is late dumping syndrome. Early dumping, late dumping, I'm giving you 30 seconds to observe this. Mainly it's the time duration. It's a time duration. And all cases history of gastric bypass or stomach or many major surgeries involved. So one more thing is common for both of them, this dietary modification, uh, smaller, meal, okay, strictly monitoring blood sugar level, lifestyle modification. So these are very, very important things actually. Multiple diets instead of like uh, two, three diets. Also supplements, vitamins, these are important. Clear about dumping syndrome, everyone? I mentioned dumping restaurant, like why I wrote that. See, imagine your early days internship, or some of you are already internship. You know, we like to eat that time a lot. It's applicable for doctors. Like at some point, we don't have much money to eat. I mean, not like in that way. I mean, anywhere we go or any buffet all the time. And there is a point will come, I mean, because of degrees, practice, this, that, we'll become 45, 50, then our degrees are finished. And then that time you have money, but you really can't eat as much as you can, right? I mean, so there's a funny quote for doctors actually. Because of lack of money, you can't eat in early life, doctors, and in later life, yeah, because of money, you cannot eat actually, because you have to keep running. All right. Now coming to this one, next one. A patient with perforated diverticulitis, free fluid on the imaging, and treated with antibiotic fluid. What is the management? Interesting. It's a new question as always of 2026. Last day, our last topic was diverticulitis, and I have shown you guys a CT scan if you remember. So CT will be given of diverticulitis. The pouch of diverticula will be visible in the CT. The pouch of diverticula, you can check. Now, coming to this one, like what we can do, some IV antibiotic, like so ABCs are given. Look like initial resuscitation is done, and they're asking for what's next step in the management. Free fluid suggests generalized peritonitis. Okay, so peritonitis normally it's a IV antibiotic, IV fluid. That is the main thing. So next step would be very important is the source control. All right. So so everyone, what do you think? It's a little complicated one. Okay. Let's see a reference. There's a nice website, Med Bullets. You can also check it. Some cases. Okay, we recommend the Hartmann's procedure for managing diffuse peritonitis in critically ill patient. Okay, that was the guideline line. Laparoscopic lavage should be used only in very selective patient, known as a first line. Some question will keep us thinking. This is one of the that question, and in orthopedics you will find another one, which is the tibial fracture related, and there's another complicated question. It's okay to have complications here, so that you can do well in the main exam. Keep thinking, guys. It's okay. It's a new one, tough one, so it's better you do your brainstorming. See, initial, what is the main supposed to be the treatment? It is being given, because in our mind, like perforated diverticulitis, IV fluid and the antibiotic. That is the main treatment. But they are asking about one step ahead. Okay. One thing we can clarify. Okay. First of all, is your patient is stable? Because this is the important question here. Is my patient is hemodynamically stable? I mean, at this point, stable now or not? Uh, Treated with IV fluids. Okay. We take few lines from the guideline. Let's say Hartmann procedure. okay, for the diffuse peritonitis. But the question is, uh, the Hartmann procedure is nothing but, is this one, like colostomy. The question is this one applicable for uh, our particular question? Okay, let's assume, because not clearly everything written, your patient is stable. Okay, because unstable patient they always tell in the MC question, first of all, isn't it? If instability, they always tell in the question. Great. Now, this is nothing colostomy, like this colostomy procedure, they use the Hartmann procedure. Hartmann. Question is this one the right one? No. Answer is a, we do it in a unstable uh, patients. Okay, that is one. Another question is coming is about the ileostomy. These are little new actually because I mean, see, they started asking a little bit more surgical procedural thing, which is usually not common in AMC. Telling you that. I have been teaching for very long. I mean, so procedural questions are very lessly they ask, but this time I found one of these questions they ask like, in depth of the procedures actually. Surgical procedures, it's quite a difficult. But there's so many surgeries, so many conditions, and now, ileostomy. Now, in ileostomy, of course, it is done also for the diverticulitis. If you see the main bullets, you'll see ileostomy is also mentioned. But question is, ileostomy is in which case? Can ileostomy can uh, correct the source? All right. So it's mostly like if it is a sigmoid, particularly, then that is actually okay. But here it is mentioned perforated diverticulism. What is the real source? It's difficult in that case. Actually, because of this condition, this patient has been treated with this. So resuscitation is probably done initially. Let's assume. We already mentioned. Let's assume. Recall, sir, that's why, hypothetical. See, perforation or the free gas, this thing eventually needed surgery. So observing in ICU may not be best idea in this case. So in my opinion, here uh, one of the best option it can be as long as considering patient is stable. I mean, stability is done. That will be given in the main exam for sure. Yeah, I mean, I'm also with someone mentioned in between D and the A. But let's assume after this procedure, if your patient is stable, they will be definitely mentioning in the question. In that case, the source controlling laparoscopic lavage would be the best choice. Okay. It's like a washout actually when you give the lavage. Okay, clear guys? If stable, if the same question considering instability, then A. If the question assume stability, then laparoscopic lavage. Now clear everyone? Oh, okay. It's a bit advanced, I think. All right, everyone. So I think what we can do, we can go for a break now because a lot of things, and then come back. You guys can keep thinking about this one in between. It's okay. We also need little fuel. Yes. Yeah, it's okay. Some complexities came up with the diverticulitis. Maybe we have to study a little bit more in coming days. So no worries, guys. Let's take a break at this point. So considering D, considering after resuscitation, the patient is stable, and then we are doing the Lavas thing. If unstable, definitely we are going for the colostomy via Hartmann procedure. Okay. So everyone, we'll see you after 10 minutes.
কেমন ভাবে লুকিয়েছে? এত কষ্ট করে খাওয়াইলাম প্রতি ওদেরকে, এখন আবার 5 মিনিটের জন্য পরে ব্রেক দিছে আবার।
All right, everyone, let's get started. All right, I'll post an article regarding that. All right, guys. Yeah, I mean, the last topic. Just taking a second for a jump on. All right. So that was a bit controversial one. We picked up D, but I mean, the question has little complexity and I would say a bit incomplete so that we couldn't get into a exact uh, management. Considering this thing as a staple, I mean, laparoscopic lavage, but we can also do the staging. I think it would be better, like there's a staging thing, which I will share that article in our video channel later. So no worries. Next one. A 62-year-old man presents with 2 days abdominal pain, distension, and cramp abdominis, hemodynamic and is stable with no pain. See, this question is a little bit better because stability is mentioned with no like peritonitis. Abdominal X-ray shows large bowel loops with a large bowel obstruction. Okay. What's the next step in the management? We have a radiology equipment. Let me zoom this one. One, two, three. I hope you got it clear here. Oh, here we go. Okay, so it's clear it's a large bowel obstruction, it's acute large bowel obstruction. So in this case, what to do? Um, it's been 2 days, patient stable, the obstruction. Okay, All right, let's double think. Ultimately, we need surgery. Ultimately, we need surgery, no doubt on that one. For a stable patient, can we go for a CT scan if we're going for a surgery? There's a one thing about CT scan. A stable patient is always like, you can send for a CT scan. All right. Every obstruction is not same. I mean, always patient is dying, this and that. Okay. So there's a differentiating point between small bowel obstruction and large bowel obstruction. Luckily, in our question, it is already mentioned that it is a large bowel obstruction actually. Okay. Yeah. So some question arises like, hmm, that is why their recalls, they're like, confusing. That will make you think twice or thrice. We can have a like extra checking, it's okay. But the recalls are like that. So many questions are like that. That is how if you do more brainstorming and this and that, things would become and very close. I mean, this kind of viginities, whether to go for a city, whether to go for a surgery. We know, I mean, things, but they will not clarify. Audio lower because I'm talking in low pitch. Resting the voice, my dear. Okay. It will be up over the time. Okay. Option B, I mean, let's just exclude the option B because that was the most close one. Option B, it's a laparotomy. So laparotomy is indicated, especially just following the particular, actually, like let's say unstable, instability case, uh, peritonitis, perforation, strangulation. Yeah. Uh, all these are the red flags. Since red flags are not the present, we have time. Of course, we'll go for a CT scan. Clear? Yes. It's one of the thing in our country we think too much about doing a CT scan. In those countries, like CT scan is quite easy doing. It's available everywhere. That's another thing. All right. So C is the right one. And it's the difference between small bowel, large bowel. Small bowel, large bowel related lot question keep coming in the main exam. All right. We're moving forward. So again, stable patient, suspected large bowel obstruction by abdominal X-ray. So next step would be CT scan to confirm further obstruction and all these things actually. Also, you can also check out if there is any complication in this and that when you do the CT. Okay. I think we're thinking too complexly. I mean, X-ray has been done, patient has been stable, sending for CT. It's that common. Example, I'll give you another compare contrast question. Let's say there's a thing called foul chest. Okay. Somebody in orthopedics will learn or emergency will learn. You heard about this fracture chest? It's another kind of emergency. So fracture chest also has, stable and the unstable situation. Most of the fracture chest cases we started with the painkiller, that is the initial, and the Stable cases, we send them for CT scan. That is the thing. In unstable cases, we don't send them for the CT scan. Clear now? So this kind of things are quite a common, like a compare and the contrast. All right. 55-year truck driver, follow up this thing as a truck driver. Yes, certainly this complaints with a chronic diarrhea, and diarrhea is for 3 months. Good news, he does not have weight loss or GI bleed. A colonoscopy performed a year ago, which was normal. What is the appropriate next step? So, guys, what do you think about this thing? We're suspecting this thing in between two things. I mean, can anyone tell me a diagnosis here? Okay, two diagnoses, one ZRDA, another one probably HIV actually. All right. First of all, occupation, but patient does not have any lower GIT bleeding, so you can exclude the IBD. One more thing, very important, IBD, because it is also chronic diarrhea. So here are some of the related things for chronic diarrhea. There are certain malabsorption, celiac, cystic, but these are more like early days actually. So for us, like IBS, IBD, CRDA, lactose, these are more important, or even cancers. So since the occupation is supporting here, so we'll think more about the uh, stool for over, because they go into different places. If it's have been HIV, they would have been give us a little bit more hint. Okay, like fatigue, this and that. They'll give you a little bit more hint. So why not HIV is first? Like they will tell you starting this question again. See, fatigue is a very important. Fatigue, weakness, weight loss, and some of the infections, immune compromise, and some cases in the lab CD4 count can be. But in HIV, these are some of the lines are also expected. Coming to the question, are we clear about this? I think most of you answered this one successfully without double or triple thinking. Also understand, like CRT is also important from the Aborigine point of view, because truck driver going in different places including Perth and many Aboriginal areas by driving this thing actually. So when they go to the remote areas, the chances of giardia increases. Next one, young child with increasing vomiting in past 3 days. So child with the vomiting case. He has been gaining weight previously but has not gained weight in last 1 week. The child is cheerful, alert, and happy, but not dehydrated. What is the likely diagnosis? Very interesting question. You have to consider CERT versus pyloric stenosis, very popular for MC Part 2 as well. So your child is cheerful, alert, and happy, and not dehydrated. Quick question: is pyloric stenosis cases? These patients are dehydrated. It's an important thing in pyloric stenosis cases. Yes, so after massive vomiting, projectile vomiting, they started feeling dehydrated. Some cases in pyloric stenosis, they will be given like a mass, like a olive-shaped mass. Okay, so those points are not given, neither a radiology given. Um, Anyways, some cases they might also tell you milk flows freely from the mouth, especially in infant cases or up to 1 year cases. Right. So this one is clearly a ZERT. We already discussed about ZERT. We're not going into detailed discussion. Are we clear about the uh, ZERT, guys? So ZERT cases, they remain active and cheerful even after the vomiting. ZERT cases, they remain active, cheerful, and not dehydrated even after vomiting incidences. All right. So ZERT and the pylorus, ZERT already discussed. There's another thing, I mean, additionally, you can remember other than the paleogastrinosis. This is more paleogastrinosis is more common with the children's version or adolescent's child, this version, whereas gastric outlet obstruction is more popular for the adult version. Here's a patient line, hear me out. Vomiting may be intermittent, and usually occurs within 1 hour of meal. This is classic for the gastric. This has been tested long back. I just add that reference so that if next time this time pyloric stenosis came, maybe by the end of the year, gastric outlet obstruction they might give you as well. So for gastric outlet obstruction, similar kind of things like pyloric stenosis, but here's spatial line, and this has been tested not recently but in past. But I added that slide for you. So vomiting may be intermittent and usually occurs within 1 hour of meal. They ask a statement type of question in past. Is it clear, everyone? Peptic ulcer versus CERT, everyone? Okay. Don't worry, pyloric stenosis will again learn in our pediatric. So don't worry about that one. Young man, maybe 30 years, presents with a mixed mucus with a mixed stool. Similar episodes, so it's again happening second time. And unintentional weight loss. History of travel 2 years ago, otherwise well. What's the likely diagnosis? Very interesting question. This kind of question very common in MC. All looks correct. So this is, what do you think? Yes, it is ulcerative colitis. It is ulcerative. So mucus mixed with a stool. Weight loss thing can happen because there are ulcers. They don't like to eat much. So it is an ulcerative colitis. All right, great. So ulcerative colitis, we have these two things already checked. About IBD, I mean, already discussed previously, so I don't want to go into more details. So initials of in acute flare-up cases, corticosteroid. I took these lines from John Mukta. And refractory or treatment failure case, which I think the last one I left over, if you remember. So this one's the relapse case. Can I say like this, guys? You can see this is a recurrent, guys. So it's a relapsing case, right? Relapsing case of inflammatory bowel disease. So refractory case, relapsing case, treatment failure. So finally, azathioprine, your treatment of choice. This one I didn't answer in the last slide. So here is your answer. IBD is getting more popular. So for ulcerative colitis, more clues. Recurrent episodes are quite a common. Chronic mucus and blood, weight loss, a long time 2 year gap since travel. Yeah. So this is too long for amoebic colitis. Actually, if you think about entamoeba histolytica, amoebic colitis, there will be more shorter history, not like a 2 years history. Clear, everyone? Why it is not amoebic colitis? Yes. And Giardia has a whole different features, staturia, those are the main things. Great. Next one. A middle-aged man with a history of surgery for achalasia. Okay. Hoarseness of voice for 1 month, dysphagia for 2 weeks. On examinations of vocal cord paralysis noted and a mass shown in the thoracic inlet. What is the diagnosis? Interesting question, popular question. This is a question I kept from the last batch slide as well because this question has been tested couple of years in past. A lot of people answer this thing as a cancer larynx. A lot of people answer this thing as a cancer of the esophagus. Now you have to decide which one is the right answer. It's a very close call, by the way. Because we're going through the GIT, a lot of people will think uh, this is related to cancer of the esophagus, actually. A lot of people. But is it cancer of the esophagus? Not really. It's a cancer of the larynx, will think first. Cancer of the thyroid will have thyroid features. So first of all, let's exclude the D from here. They don't have any thyroid features, first of all. Cancer of the lung has other paraneoplastic feature, which I will tell you in the respiratory class. Cancer lung has a different features plus paraneoplastic other features. That's another thing. All right. So one more thing, here is a vocal cord that can probably get involved anyways. But main feature is here, like how we solve this question. So laryngeal cancer, hoarseness is early and the prominent symptom. So based on the hoarseness first, hoarseness over dysphagia. So few things just write as a formula, hoarseness over dysphagia. This will help you in the exam. Hoarseness duration is over dysphagia duration. Diagnosis, laryngeal cancer. Dysphagia duration over the hoarseness. Then that would be esophageal cancer. So few things, exam wise, I mean, you can think so many things as a DT. We know this, we are also physicians. But thing is actually few things for the exam we have to remember in that way. So hoarseness thing, because it's an early and prominent symptom for laryngeal cancer. Even laryngeal cancer has many other symptoms too, that which I will teach you in the ENTs. For this one, it's a very important and differential. So esophageal cancer versus you always need to double think about the laryngeal cancer. Okay. So final diagnosis, cancer of the larynx. So cancer, larynx. All right. Sorry, I put that answer prior. 30-year-old underwent appendicectomy and histopathology of 2 millimeter adenocarcinoma on the appendix. Okay. What is the most appropriate next step in the management? So I think again a similar one, I think, as like before, stable. So you see, this is again clinical reasoning type of question. Have you realized like this kind of pattern they're following more? If anyone has followed previous question, uh, so they are going for either you are going for a surgery or either you are going for a investigation. So more clean, these are called more clinical reasoning question. Those are more expert physician or expert thinking based on the nostril guide, not expert in our countries. Expert thinking in on the basis of those guidelines will able to crack this more faster. Right. So you need the CT scan because you need to rule out like more staging is important. You need to do more staging and this and the CT scan is important here. Yeah. So based on the AAFP, yeah, that's one of the popular. So CT scan of the abdomen is recommended for suspected high grade, yeah, these situations. All right. This will decide the mode of the treatment. Why CT? This will decide the mode of treatment. Am I right? Yes. Clear, everyone? I think this one looks easy because last one was looking dark, but now it's easy for us. If this came first, I mean, would have been troublesome. AAFP is a physician thing. So certain points are given, which probably you can take a screenshot or maybe you can check AAFP and you can check the this particular topic of obstruction. Few lines are given. Closed loop obstruction should be treated as surgical emergency. Abdominal radiology is appropriate initial. So X-ray for GIT cases always being considered initial, although CT has greater sensitivity specificity. Plain radiology always considered as an initial diagnosis option. Who are yeah, step unstable to go for further imaging actually. Then you do like some cases X-ray and quickly go for a surgeries. But CT scan, you have to send him to a CT scan machine, CT scan room. So unstable patient you cannot do actually. Okay. Anyways, few more lines are given. You can check it by going to that particular website. This is how you can enhance your knowledge more. Severe pain and out of proportion and atrial fibrillation history and lactatus increase. Best test in this case. Yes, please. A lot of people with C, a lot of people with D. Severe abdominal pain. Let me clarify that. Severe abdominal pain proportion and there is atrial fibrillation history. Can anyone tell me what can be the diagnosis in that case? Abdominal pain is a big term that is include medicine, that includes surgery. Someday when we'll go to the surgery, then we will be already knowing this medicine topic will be more easy. So this is mainly a abdominal pain topic with a special, thromboembolic manifestation history like atrial fibrillation, which is a thromboembolic manifestation history. With that one, there is a thing given lactate. When the lactate thing is given, this is considering when with a abdominal pain. And let me tell you, original exam will tell you this will be a severe abdominal pain, almost 9 on 10 pain, or a very severe pain. So this is nothing but a mesenteric ischemia. Heard about this mesenteric? Yes. So it's a mesenteric ischemic pain. In mesenteric ischemic pain, there will be history of other thromboembolic like atrial fibrillation, and there will be severe abdominal pain, and there will be increased amount of lactate. Another thing, uh, it's not given in this question, but pain increase after eating. Is that true in mesenteric ischemia? Pain uh, increases. Yeah, because when you eat, the blood flow get hampered in the and when this mesenteric ischemia, so means arteries are already affected, and now you eat more pressure, more pain. Okay, so this is another thing. Can I also tell another thing? The pain is specifically common in which part of the colon? If this is the colon, there are two areas which is called flexures. So pain is particularly more in the flexures because this part has constrictions. So hepatic flexures, splenic flexures, these areas, the pain is even more. But the question is, what is the best test in this case? They ask best test. So in this case, I think the CT is considered. Why not D dimer? Like some people are choosing D dimer, but it is a non-specific test. Am I right? D dimer as a support you can do, but it's a non-specific test. So specific is a CT angio. Clear, everyone? Same goes with the pulmonary embolism. Compare, contrast, another thing. What is the confirmatory test for pulmonary embolism? Can anyone tell me? There's a X-ray initially, later you can do D-dimer. But how to confirm again? So CTPA to confirm, right? So it's similar kind of question, thromboembolic type of questions actually. You see one thing, this is so lactate increase in mesenteric ischemia. Lactate is something which increased in mesenteric ischemia. They can have a history of other heart issues. They have abdominal pain. They have lactate issues. Yes, so some other tests like heart checking is important and also mesenteric angiography, eventually what you need. Yes. What is the gold standard of the treatment? Guys, if I ask you, since this is mesenteric ischemia, what is the gold standard treatment of mesenteric ischemia? Ultimate treatment of mesenteric ischemia is a urgent. Is it an emergency? Yes. That is a gold standard treatment. That is a gold standard treatment. So they have a lot abdominal pain. Some cases they can have vomiting, a little flush of diarrhea, and also some cases bloody stool it can be, but not a classic bloody stool case. Next, young boy presents with nausea, vomiting, diarrhea after 24 hours of a camping trip. Now, this is more related to travel, This is related to medicine. This is related to pets. This is related to, I mean, population health and many other things like infections. Many category you can put. Now, which is the likely microorganism in this case? Okay, yeah, very young boy. Okay, understand one thing. This young boy is traveling inside Australia. Okay, very young boy. Let's say 10 years boy traveling inside Australia. Now, young boy traveling outside Australia and going to, let's say, Asian countries. Now you will think more about the E. coli as a first choice. That is out. It's not common in knowledge in Australia. Very like, strict about food and all these things. Now, they say 24-hour. Okay, a lot of people are with C. I'm very happy for you guys to draw this for you. Some people are quickly changing their answers. Now, what is this? It's a little therapy for you guys, which time to time I'll give you guys. All right. Now, coming this one as a virus. Viruses are quite common in those countries instead of the bacteria. Very interesting. Viruses are more common in those countries, I mean, outbreaks, rather than the bacteria, because the hygiene is so good in those countries. So, young boy with a nausea, vomiting, direct. They say 24 hours after. Now, your question is salmonella. Is salmonella is 24-hour after? No, no way. Salmonella is like 6 hours, 2 to 6 hours. Salmonella is like 2 to 6 hours. Please check there with some medicine intubation periods. Right, guys? Can it be Giardia? Giardia is a case of chronic diarrhea in one short trip you are not expecting. Yeah, yeah, stuff is like, up to 24 hours this time. This is like, after 24-hour actually. So I think I would prefer more towards the norovirus. And it's also very contagious. They also say the other children also has the similar kind of issues. Now, let's say is the bacterial, are you expecting the same? The other children also have the similar, all of them kind of, other children also have similar symptoms. So the viral outbreaks, especially in the camps, are more common. The viral outbreaks, especially in the camps, are more common. In Australia, food related things are less common, like the bacterial, because even if you go little outside, the food regulations are very high actually. All right. So here is a little bit thing. I think 30 questions. So I think 8 more left. All right. Be patient, my dear. It's for or you're limited. If you don't have the patience to stay in a class for 3 hours, no point of going for AMC. Every time those people left classes fail in the exam. Trust me. All right. So need to have that mentality and the habit. You have kids, you have like small babies, you have uh, large babies, whatever it is. Large baby means, that big ones, your partner. All right. So, anyways, whatever it is, keep them aside, focus on the classes. All right. So, anyways, so you can see, yeah. So that's best fit actually. So Giardia much later, it's a chronic salmonella. You see, it's given 6 years as possible, but normally we count salmonella as like up to 24 hour, practically speaking. So Shigella like 1 to 7 days. So Shigella it can be, but they didn't mention about bloody diarrhea. So Shigella is out, no bloody, right? Shigella is out actually. E. coli it can happen, uh, but expecting more serious situation with E. coli, and at the same time traveling inside the Australia. I mean, it's less common with E. coli rather than the virus we think of. Okay, guys, clear the concept? Is it clear the concept? The reference I took from the CDC, so CDC is good. You know about CDCs. So acute vomiting, diarrhea outbreak after the camp, norovirus, think more. prolonged greasy diarrhea after, so then it is giardia. All good? Okay, here is a little reference for the handbook, guys. I recommend you to study the handbook side by side of the class. So, MC handbook, which is also known as this color book, blue book. So there are certain sections given, and but GIT is not given separately. So class to class, I'll tell you the numbers. Okay, so please take a picture of this one, or I'll post this one in the group. So no worries on that one. So class to class study is important, the handbook. So I'll help you, reading that book. Because otherwise separately reading can be a little bit time consuming for you. So keep that in mind. Clear? Okay, next one. We'll try to finish the remaining day. 48-year woman admitted to the emergency department. So it's a question related to emergency, productive cough fever, and central chest pain. Yeah, rheumatology post as well, no worries. Okay. And regurgitation of undigested food, and food most times does not suffer from acid reflux. The symptoms have been present for quite a time, affects the food and the drink. Okay, so dysphagia for like a solid liquid. Effort level um, behind a normal size heart. What is the likely diagnosis? Interesting question. So they have a productive cough and a fever and certain points. X-ray showing effort level behind a normal heart. Okay. Okay. Patient presents with a central chest pain. Now, if patient is present with a chest pain or a heartburn, can it be achalasia? Like some of you are thinking about achalasia. Could it be achalasia by any chance in that case? I don't think so. In that case. So the diagnosis is going more towards the pharyngeal pouch actually. Diagnosis is going more towards the pharyngeal, the pouch actually. We already discussed about achalasia things actually. It can be achalasia as a good one actually. Even some achalasia cases, it is possible, like little heartburn or chest pain. That is possible. Right. Next one. A 50-year male and his father died of colon cancer, 57. We do have a screening session, so don't worry, first of all. His maternal aunt has colon cancer too. It seems a little incomplete question too, but yet we can. How will you screen him? Original questions are 4 or 5 lines. First of all, there is a family history positive. So father died of colon cancer and his maternal aunt also has colon. So there is a colon cancer runs in the family. Our patient is a 50-year person. So I think at this point for him, let's say how to screening him. Okay. I think it's a colon cancer now is better. I think best option is missing. Yeah, I think this is better. For previous question, follow exclusion method. When the others are not supporting, then it's going towards the pharyngeal pouch actually. I mean, it's not straightforward, but hiatus hernia, you need a obese person, ZRD features, bulbar palsy is like more like neurological thing, so it does not related to this question. TB is not even related anywhere. And achalasia I already mentioned, it's not matching. If these are not matching, it's a pharyngeal pouch. So going for next one, patient is given amoxicillin, gentamicin, metronidazole, and Clostridium difficile. positive. What is the next step in the management? So there's a thing called antibiotic associated diarrhea. Now, in antibiotic associated diarrhea, what do you think is the next step in the management would be better? So I think final answer would be vancomycin. Final answer would be so antibiotic associated diarrhea, Clostridium difficile. The final answer is yeah. So initially we try with metronidazole as well. I mean, controlling this situation. And if metro not working, in that case, vancomycin. This situation also known as pseudomembranous colitis. The question is, what is the first line? They can also ask you, this question I have seen in MC in various way. What is actually the first line for this one? Any idea? So first line would be withdraw offending agent. In this case, this is straightforward. This is a culprit drug, so withdraw that offending agent. This is the first thing to do. Then the second thing that is coming, you can try with a metro, but which has been already tried, and then coming with the vancomycin. It is often because of a secondary antibiotic use like Clinda or this thing. Okay, one more extra question, which some of you, some cases should know. This diarrhea pattern is what type of diarrhea? Watery diarrhea, bloody diarrhea, or uh, what do you think? You should know this information. This diarrhea, Clostridium difficile associated diarrhea, is a watery type of diarrhea. Okay, so John Murtak, you can follow up the page. Watery diarrhea, profuse watery diarrhea, within 2 days of taking antibiotic, most cases. So your priority would be ceasing, yeah, antibiotic. So cease antibiotic, metro, and then vanco. Also consult with a specialist important, be aware of toxic megacolon. So it is a possibility that this question in future can come also as a megacolon. So megacolon, toxic megacolon we've seen with ulcerative colitis, but megacolon can be given as a part of Clostridium difficile as well. Clear, everyone? Here's the one line I want to address: fecal microbial transplant. It's a new name for you, considered for recurrent infections. So Clostridium difficile usually it's not common for recurrence, but if it's a recurrent by any chance, then fecal microbial transplant. Okay, everyone clear now? Clostridium difficile or antibiotic associated diarrhea. So metro, 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 then the vanco. One more thing, long back I've seen a thing, giving vancomycin, there was side effects. What side effect? Red man syndrome. Please remember this. Vancomycin, ever heard this thing? Red man syndrome. Extra. Next one. 25 years, have asthma, child with GERD. Now he feels trouble with certain foods. Endoscopy is showing mild. So thing is given. Now what to do in this case? I think it's a similar sort of questions. What is it? Okay, everyone. So let's go for this one. Some of you choose this one, but if you remember eosinophilic esophagitis slide, I mean from the last one, yeah. So I think this thing was given fluticasone, if you remember. Budesonide, I mentioned last time, and there's that fluticasone was mentioned. Okay. Eosinophilic esophagitis, fluticasone has been mentioned actually in the John book, like in the last slide we have shown you. So going for next one. Sudden vomiting dysphagia. We all are tired. Yeah. So just two, three more. Sudden vomiting dysphagia, epigastric pain, patient who had previous gastric fundoplication. This is an uncommon one. What is the investigation you want to do? Interesting one. After gastric fundoplication. This one I didn't taught previously, but I'm sure you guys are smart enough. And one line I mentioned, like all these particular cases, the initial is always a barium actually. Okay, so it's a barium solo. So any other procedures you do, like a gastric fundoplication or LAGB procedure, you see, if you're suspecting any sort of complication, like say sudden vomiting and dysphagia, and considered as a complication after this surgery, you see surgical procedures they are asking more, which previously they were not asking more. So more clinical reasoning, more surgical procedures. This is an update. You need to learn about some surgical procedures also now actually. So barium solo, yeah, is the investigation here. So in this case, you see this one with the vomiting and the regurgitation. So this one is a barium. So there's another option can be given, which is a gastroscopy much later, and some other complication, then you can go for gastroscopy or endoscopy thing. But here in this case, the barium solve. They also didn't offer you the gastroscopy, so you don't have to worry. Clear, everyone? This thing, things are getting a little uncommon by the end. That's okay. Okay. Next one thing, patient given this some drugs. And okay, sorry about a repeat one. Clostridium difficile positive. I think oral vancomycin. I'm sorry about that. Okay. Metro already given. Okay. Severe ulcerative colitis, fever, tachy, and colon dilatation. What is the next step? All right. So again, a IBD question. Again, one particular IBD question. Since severe ulcerative colitis, because not mild, moderate, severe case or much recurrent cases, you need a surgery. All right. And before going for a surgery, when it is severe or if it is acute, you need to control the situation with steroid and go for a surgery. In this case, avoid colonoscopy because they can already have complications. So IV steroids and urgent surgical consideration. The higher chances they can also develop megacolon or this and that. All right. After a conference mail, I think this one maybe I have shown you as a separate question. Feel floated and forced vomiting, then suddenly pain in the retroperitoneum and got ischemic heart disease before. Okay. Keyword, guys, conference meal, forced vomiting, and after resuscitation was it is the appropriate step. This one I think you remember. Anyone remember the diagnosis? Anyone remembers the diagnosis? Yes, well done. If you're thinking about there's two esophageal conditions, if you remember, which can happen after forced vomiting, often after a binge eating. Binge eating means when you're eating a lot amount, right? So two of them can be one is a Boerhaave, one is a Mallory West. Which one is more dangerous? Boerhaave sir is more dangerous if you remember. So it can be, yeah. So in Boerhaave's cases, what we can do, we can go for a lateral chest X-ray. Boerhaave's cases, we can go for lateral chest X-ray. Yeah, if you remember this, Boerhaave case, after initial resuscitation, we can go for a lateral chest X-ray. Patient can develop a certain pneumothorax type of situation. And in this X-ray you can see in Boerhaave's, it's actually, yeah, this one is deviated. So extreme pneumothorax cases, your midline shifting, it is possible. The same one. So Boerhaave's, I only found this one particular question. So I kept it actually. This one is not a new one. I kept it in this file. Yeah. So anyways, otherwise solving this one can be difficult if you don't know how to solve it. So lateral X-ray, please remember it, lateral X-ray. If they ask you about the treatment, like let's say they didn't give you investigation, they ask you about treatment, what will be the treatment for the Boerhaave? It's an emergency, but ultimate treatment is after resuscitation, definitely you need surgical repair. Definitely you need surgical repair. Okay. 40-year patient traveled to Indonesia, central abdominal pain, transformed to this, that, nauseous, diffuse abdominal pain, chin, rigor. No sign of peritoneal irritation, not peritonitis, otherwise normal, except for painful diarrhea. So, with the painful digital rectal examination, is the most common cause of primary symptom. Come on, guys. Painful diarrhea is a special line. So, we are going for the Crohn's disease. There's a special line actually. Crohn's disease has a lot involvement. Upper part of the GIT, the lower part of the GIT. Crohn's disease involvement, right? So you can see a lot areas are involved, involves other areas of the GIT, whereas ulcerative colitis does not involve the other areas of the GIT, mainly in the rectum. So now is it clear, everyone, why this is Crohn's? Okay. Patient with esophageal varices, previously repaired twice. Now again, this topic I will teach you in future again, no worries, but it came up. Which approach is better for him, as well as lessen the chance of hepatic encephalopathy, which I haven't taught you guys yet. But since part of the GIT, sometimes this esophageal thing came up actually. It's okay. You can think about this thing as a lower GIT bleed. Lower GIT bleed can aggravate, hepatic encephalopathy. Even in our country, recently an influencer died because of like encephalopathy, liver failure, and followed by not the same exactly. So here's the question which approaches bit of him to lessen the chance of encephalopathy. A lot of people are answering tips. All right. Now, many of you don't know probably this one. Tips itself is a big procedure, and in tips, while doing the tips, it will aggravate the encephalopathy. So certainly, tips is not the procedure actually. Instead, what is the procedure actually is, yeah, is a splenorenal. So this one I think is new things which you need to learn from us. So splenorenal shunt, also known as the Warren shunt. This is one of the things which actually, low incidence of hepatic encephalopathy. Any other procedures increase the chance of hepatic encephalopathy. Don't worry, in future I will teach you guys the hepatic encephalopathy thing. So leave, this one Warren shunt or splenorenal shunt. So distal splenorenal shunt, also known as the Warren shunt. This is new to you, so don't be frustrated. We are learning. Okay, so is it clear, guys, so far? Yes. One more. A 18-year, very young, bloody diarrhea, and you made sigmoidoscopy and 30 centimeter fiable mucosa. I think this line I separately mentioned. Friable mucosa. So if I talk about the fibril mucosa, it is certainly going towards one particular diagnosis. Fibril mucosa certainly going towards, yeah, area of fibril mucosa, ulcerative colitis. If ulcerative colitis, your treatment is sulfasalazine. If ulcerative colitis, then it is sulfasalazine. We already discussed, right? IBD cases, early cases, it is always sulfasalazine. We also discussed if acute flare-up, steroid. We also discussed refractory cases. We can go for azathioprine. All right. So here are a few things about the ulcerative colitis. The management exactly lines from the John mode that you can see. So sulfasalazine, steroid, azathioprine. There are also surgical options available, but that is reserved for complicated cases. Example: ulcerative colitis can leading to emergency situation like toxic miraculum. Okay. So young one coming from a trip and blood mucus. It's a little, I think, similar with one of the question. I think we choose this one as an ulcerative colitis. It's too long history for this one to be called amoebic colitis. A similar kind of we have seen. This one is a repeat. We choose as CERD. Don't worry, we're almost finishing here. Okay, let's check this question. I'm not reading this one. Read this one and go for an answer. A clue for this one is all like some of the tests, serum, amylase, lipase, troponin, all are in normal parameter. Pain, which is radiating towards the back, that's probably one of the early, you know, symptom. Please go for it. All right, everyone. So I think in this case, actually, this is abdominal pain related. Another question, bit mixed of medicine, surgical, hepatic. Uh, Special line, serum amylase lipase can be normal in early stage. I repeat, amylase lipase. So from your practice, guys, so again, this is a clinical reasoning question. Am I right, guys? Like your amylase and these things can be normal in early stage of pancreatitis, yes. But the main thing is yet, like, pain which can radiate to the back. Pain which can radiate to the back. Clear, everyone? So it is a pancreatitis. Yet it is a pancreatitis. Now, almost at the end. A patient has been given investigation of GERD. I think it's a similar one, just a little bit different variation with a bleeding peptic ulcer question. So the breathing 50 answer question. I think this one, injection adrenaline into the directly into the place, that is one of the main one. So bleeding peptic ulcer is the answer. I think today's last question. Old woman with calcium and other blood report, and what is her cause of having low calcium? Does not really mention that, Asian background or Australian background. Let's go for it, guys. Let's finish it. I think it's a dietary deficiency until proven. Low calcium or low vitamin D, these particular things are, especially low calcium is a dietary deficiency until proven. It's a elderly person. So elderly person automatically they have very high chances because of the bone loss, low calcium. So it's a dietary deficiency until proven otherwise. Periumbilical pain migrating to the uh, this particular right iliac fossa, anorexia. What is the best next step? Periumbilical pain migrating to this particular. So what do you think? So I think it's a surgical review and we should think about probably appendicitis. So surgical assessment and imaging is more important at this point. Abdominal pain related, some of the more information, it can be appendicitis has like this particular pain radiation, where pancreatitis radiating directly towards the back. It's important. Diverticulitis associated with lower GIT bleed. That's another important thing. Also, some cases fecal infection can be a key point for diverticulitis. CT scan will show pouch of diverticula. Fecolith in appendicitis cases, you can see. Cholecystitis, that 4F, female, fertile, fatty, all these words, so, and pain radiating to the tip of the shoulder. Okay, so this is how we can differentiate. And after the GIT, we'll have the cardio, and you'll see the chest pain related. We'll also talk about a lot of things actually. Abdominal pain related, we'll also talk about in future. There will be surgeries, there will be gynae. All will have abdominal pain related thing. Is abdominal pain is easy or more complex, guys? The typically abdominal pain, it's usually more complex. Abdominal pain, not all abdominal pain are so simple actually. With the following is the first test to be performed in a patient with a lower GIT bleeding. Yeah, this kind of question they love a lot nowadays. A test they prefer to perform in lower GIT bleeding. It's a colonoscopy. If lower GIT bleeding is a fresh bleeding, we may not perform always the proctoscopy. So it's a colonoscopy. It's a colonoscopy we would prefer more. All right. So here we go with the lower GIT bleeding already discussed in the last class. Sorry, we had to rush a little bit at the end. So there's lower GIT like diverticulitis, angiodysplasia, then the colonic cancers, and some of the conditions like IBD needed to be considered actually. This part, we have shown in the theory class. If anyone missed the theory class, please go and check in our YouTube, or I will post or share it in from my Facebook profile again in guideline group and other groups again. In any case anyone missed that one, can double check this one again. We started today's class with some of the second grade updates, with some Aboriginal and this and that if anyone joined late. Earlier we discussed few things and some of these topics for Aborigine, we have to study more and already mentioned about few things like clinical reasoning more. Some examples already I have shown. Some patient safety more protocol like ethical cases we'll see more. And already, indigenous health and Aboriginal health. Aboriginal, there was a slide and things I will discuss more, like even anti-racism, like, we have to study these things. All right. So thank you so much, guys, for attending this session. I hope you enjoyed the GIT things. I will upload the recording tomorrow. So thank you so much, guys, for understanding. Good luck. If anyone is left over for admission, or if you have some friends, feel free to mention them. We are still in the early stage, so still people can take admission. So tell your friends if you like the classes. Thank you so much, guys. A- Again, lastly, if anyone looking forward to contact, this is the WhatsApp number. You can save it. Thank you again. Hope you enjoyed the session. Yes, of course, we'll upload the PDF. Thank you, everyone. This is the end of the session of the GIT course.